Good morning and good afternoon, everyone, and potentially even good evening, depending on where people are joining us from the different parts of the world. Thank you for taking the time and having the energy to join us. I am so excited about today's presentation as we learn about patient experience from one of our Veterans Health Associations. Dr. Cynthia Beal is going to be presenting to us, and she's driving the slides. Cindy, if you want to go ahead and share. Nobody has any conflicts of interest to declare. So just in terms of some updates for the collaborative and other activities that we have going on, the collaborative conversation that we had last month was about Influence Ignited, which is a digital course and membership that we've started for nurses and doctors and pharmacists and whoever in the healthcare field may be interested, having people join us to actually go through some of the curriculum and use it as an opportunity to vet and share and discuss within a group and small group of interested people any quality improvement projects people may be thinking about doing. We use the DISC assessment, but from a communication perspective, not a personality perspective. And then also use 6 working geniuses to discover our natural born talents and where we fit within a team. And so by leveraging our communication style and understanding the communication style of others, as well as the natural talents of others, we want to help individuals become more effective at leading and applying appropriate skills at different parts and stages within a quality improvement initiative. So we do base it on COIL, which is what we use within the collaborative as we're rolling out the organizational learning methodology, but we've translated it into individual methodology so that individuals can learn and become more effective. Our next major course will be in January, and then between now and then, we're going to have a couple little mini courses or workshops that do just the DISC component to get people interested. Maybe that's the only portion that someone really wants to do. So we're trying to make it as flexible as possible for everyone. So be on the lookout for that. Another announcement is that we're going to be starting a weekly newsletter. Maybe twice a month is a better place to start. Twice a month newsletter that will go out to anyone that's involved in the collaborative and then anyone internationally interested in what we've been doing as a collaborative, just to keep people as informed as possible. You know how much I harp on intentional knowledge dissemination and sharing everything as broadly as possible. Well, now we actually are going to walk the walk and do the same ourselves from an organizational perspective, as well as an individual interest perspective. So if anyone has any ideas or anything specific they'd like to see in a newsletter that would be of interest to them, please send us an email. Allison, myself, Christy, any of us. And I would love to incorporate your ideas into our content as we get going with that in December. Now we'll move forward to the learning objectives. And Dr. Beal took the opportunity to highlight for us those learning objectives that we will have the opportunity to experience over the course of the next 40 minutes in terms of participating, things to discuss, evaluating the case, looking for opportunities for improvement, and then strengthening our community engagement. And with that being said, we will actively be using the chat feature. So if each of you could find your chat feature and have that open, we'll be asking questions as she is presenting. And then any questions that you have or thoughts that you have or something that you've seen in your own clinical area that you want to bring up, we would love to have that conversation ongoing through the course of the presentation. Next, so I'd like to introduce and turn things over to Dr. Cynthia Beal, who just finished her DNP. Congratulations again, and it is an absolute honor to have you here with us, and we look forward to hearing your conversation. Please provide any other details from your background that you think are relevant or of interest that you would like to share with us. I prefer to let you do that instead of me because you know your story better than any of us.
Hi, everybody. Thank you for having me today. My name is Cynthia Beal, and I want you to know that I really appreciate your time as we review this case. As Dr. Huddleston said, I just recently graduated. Most of my work has been in military healthcare systems with trauma and critical care. I transitioned to the VA about 3.5 years ago, and we've been working to build our mortality program to leverage improvements in care and change the system to help our patients. So I'm not going to spend any more time talking about myself because I really want to have time for the case discussion with you guys. And I know that our time is limited. I do want to thank Dr. Huddleston and the HB Healthcare team for giving us the platform to engage in this case-based learning. We're going to get right into the case. This patient is a 74-year-old gentleman with a history of heart failure with an ejection fraction of 35% as of mid-2025, mitral valve regurgitation, status post of valve clip, and pacemaker placement in early 2025, ischemic cardiomyopathy, coronary artery disease, two-vessel CABG in 2011, hypertension, hyperlipidemia, and type 2 diabetes. And so this gentleman presented to our emergency department with concerns of some new wound drainage from a right groin surgical site that had increased in the amount of drainage, as well as some increases drainage from his wound vac site. I'm sorry if you guys can hear, my dogs were barking because someone came to my door. So I really apologize if that's distracting you.
We can't hear it at all.
Wonderful. That makes me happy. Okay, so the patient reported swelling in that right groin site near the area where vascular surgery had previously performed a procedure on the 29th of May. And that surgery involved a right femoral to anterior tibial bypass graft and a vein patch due to chronic limb-threatening ischemia. He had a wound vac that was placed on that distal leg as well. The patient's wife had reported that the swelling had began approximately 1 week prior to their presentation and had significant purulent drainage that was noted from the previous day. They had tried to come to the ED prior to this episode, but there was long wait times, so they left and then came back. There was no associated nausea, vomiting, or diarrhea, and the patient reported no recent falls. He had been using a condom cath at night, and he was taking Eliquis. Additionally, he also had a right great toe ulcer that had developed 5 months prior to this admission, and he had been receiving routine wound care. His wife had also noted some increased forgetfulness and confusion, including some hallucination-like behaviors, which started the previous day. His pain report was reported as 7 out of 10 and was primarily associated with the ulcer on his toe. So his physical examination, his abdomen was soft. He had some minimal right lower quadrant tenderness. His groin had a large area of induration with some fluctuance, and we expressed cloudy greenish purulent drainage from that site. The area was warm, it was tender, but did not extend into the scrotum. He had bilateral lower extremity left greater than right pain with movement at the hip, and that was related to the groin pain. He had 2+ pitting edema to his left lower extremity. His right leg had no signs of gangrene around his ulceration sites. The right great toe ulcer was noted to have some serous drainage. He did have a wound vac in place on the anterior lateral proximal tibia and a rash with some swelling and induration, fluctuance, and associated discharge on that right lower extremity. He also had some ulcers on that lower extremity that had serous drainage. Significant laboratory findings where he had a white count of 14.7, his CRP was 18.89, his glucose was 258, BUN and creatinine was 48 and 1.4, and his BMP was 1463. We did take wound cultures and those, as well as blood cultures, and those later resulted with moderate gram-positive cocci in pairs, heavy Enterobacter, moderate MRSA, and light Aerococcus. So throughout his hospital course, we ended up admitting him with a diagnosis of infection of the right groin surgical site. We started him on broad spectrum antibiotics. He had referrals for general surgery, who did further evaluations and management of that infected surgical site. We took him to the OR the following day for an IND of that right groin abscess, in which we did a 12 by 8 by 3 centimeter muscle explantation of that PTFE bypass graft and then a bovine patch repair of the CFA. He went back for a washout on the 22nd, where there was a large old hematoma evacuation. We irrigated that copiously until the effluent was clear, put in a large Penrose drain for continuous drainage. 2 days later, we took him again on the 24th for a washout, in which we were able to do a light debridement, and we did notice a large clot. So he had an open cavity hematoma removal of about 300 cc's, and we put a wound vac on that site. Pain management strategies were implemented for his right leg ulcers. That was the area that was bothering him the most, and wound care was being provided as we managed the ongoing drainage and care of that infected site. His mental status was monitored. We did cognitive assessments, and we were addressing concerns about his increased forgetfulness and possible hallucinations. Ongoing treatments included monitoring for signs of sepsis, updating his wound care regimen, managing his anticoagulation, and adjusting those medications for pain and infection control. And then he was just closely observed in the ICU for further complications, including worsening of those foot ulcers as well as systemic infections. So on the 27th, a code blue was called and CPR was initiated due to an acute hypoxia event where the patient went from the high to mid 90s and desaturated into the low 70s. He became bradycardic with his heart rate dropping from around 110 down into the 60s, and then he went into PEA. His heart rate was 62, 100% V-paced. His blood pressure at this time was 127/72. And then they noted his respiratory rate at 102. However, that was secondary to the compressions that were ongoing. His PO2 was 51%, and so he was intubated immediately. His wife was called at this time to confirm his full code status. We did a 12 lead on him to take a better look at those rhythms. Our findings were that he was 100% V-paced. His rate came back at 130 because the Lucas was in use, and the SICU attending was notified at these events at 105. The code went on for quite a while, and his wife was contacted again at 122, in which she requested to continue all life-saving efforts. So at this time, we did a TTE ultrasound. We were able to rule out cardiac tamponade as well as tension pneumothorax. Thrombus was ruled out as he had no history of DVT or PE, and additionally, he was on Eliquis prior to his admission, and he was on Lovenox the same day he was admitted. Toxins had been ruled out. The only new scheduled medication that he had was ketapine, and he had been on that medication for several days without any adverse effects. Hypoxia was ruled out since we intubated him and resolved that issue. Hypovolemia was addressed, and his CBC showed a stable H&H with a hemoglobin of 8.5, and he had no source of acute bleeding. Hypo and hyperkalemia were addressed. We did an ISTAT, which showed a potassium of 5.4, in which he was shifted and then resulted at 4.1. Hypothermia was addressed. His temperature was within normal limits. During all of this, we also placed an A-line just to get a more accurate reading of what those blood pressures looked like. His wife was then contacted again at 136, in which all reversible causes had been identified and treated, but the patient remained in PEA with no return of circulation. She once again reiterated that she would like us to continue all life-saving efforts. Vascular surgery team and the attending were contacted at 137 of the situation, and then his wife ended up arriving at the hospital around 1:55 in the morning. So the code continued after this. During his pulse checks, his defibrillator was pacing at that rate of 60, and weak pulses were audible from the Doppler. At that time, we were unable to determine if he was being paced if his pacer was causing the audible pulses from the Doppler versus him having true ROSC. At that time, his vitals showed his heart rate as 60, 100% V pacing. There was no non-invasive blood pressure. The A line was showing 75/75, so essentially it was flat. We were getting no pulse ox readings, and his end tidal was at 42. The consensus was that the ICD at that time was what those weak pulses that they heard were coming from. After all of the reversible causes were identified and the situation we were in, he ended up being pronounced at 205. And the consensus at that time was that the most likely cause of death was due to his heart failure and cardiogenic failure. I know this slide is busy with a lot of times on there, but I kind of wanted to give you, I've been talking to you and giving you a lot of time frames and that things happened. And I wanted to give you a detailed perspective of what that time actually looks like. I did try to plot it out, but there was so much on it, it just became really difficult to read. So I just kind of wanted to give you guys a minute to take a look at this so you can kind of get a little bit of different perspective, a better perspective of the length of time, the amount of medications, and different times that his spouse was contacted during this event.
Couple of questions while people are looking at this. And if anyone has any other clinical questions for clarification, please do so. I mean, this is a safety and SLS collaborative committee meeting, basically, where we're all coming at it from different perspectives. Dr. Beal, when he came in, so he started hallucinating, he had the mental status changes, clearly had signs of sepsis when he showed up, given the amount of pus and everything that you found. What were his blood pressure pulse ranges when at presentation and leading up to that first surgery? Was he rock solid stable the whole time?
He was tachycardic around 108 to I think 122 was his highest, but he hung right around 110. But his blood pressures looked pretty great. I mean, he was running within 130s over low 80s, so he wasn't hypotensive by any means.
Index wasn't positive.
His blood sugars were high 200s. They actually went up into the 300s. He was started on an insulin drip. It was really hard to get those to a really good, reasonable level. So despite the fact that he's insulin dependent, it didn't appear that maybe he was medicating himself in a way that kept it closer controlled, because we really struggled with that when he was in the hospital.
Was his wife present? How long was he in the hospital before he coded? Roughly.
10 days. And his wife
was present throughout?
She was present throughout. We actually had put her, we have a facility called the Fisher House where patients or family members can stay. It's right across the street from the hospital, and it gives them easy in and out access to their loved one who's with us.
That's a nice service. Does anyone else have any clinical questions or clarifications?
Okay, I'm going to move on to the next part. This is where I'm going to hand this off to you, Dr. Huddleston, and let you lead this conversation.
I have one other clarifying question first. Was he in the ICU the entire stay? So admitted from the ED to the ICU?
Yes.
And was not intubated at all until the code?
Yes, you're correct.
And did his AICD fire at all prior to his code?
Not that I saw anywhere on any of his EKGs or in any documentation.
Okay. Melissa asks, was there discussion earlier in his admission regarding his code status?
There was not. His last discussion had happened in his previous admission, which was in May. So the goals of care discussion did not occur until this event.
And the previous hospitalization was his surgery. So clearly yes. He was full code for the surgical procedure.
Yes.
No discussion about code status on admission, it sounds like. Dr. Perry asked?
No, the only thing in the note said there was no changes.
So discussion plus minus, but clearly not a full goals of care conversation.
Yes, correct.
Now, refresh my memory, there's some required documentation within a day or two when veterans are hospitalized about goals of care or code status?
So we don't specifically have a time frame. We do look at the life-sustaining treatment note, and that's the one that should be done when the patient comes in on admission.
You have one?
He did have an LST note, but it had just said no changes. So that's as far as it went.
Okay, please come off mute or type in the chat. But I'd love to hear from everyone what you think the high-level categories, and maybe even subcategories for those of you who know them. What types of opportunities for improvement can we think of that may have occurred for this case? So if we were sitting in the committee room and Dr. Beal had just presented the case to us, what would we be expecting the opportunities for improvement to be? Dr. Beal, Dr. Perry asked if the wife was really not called about the events until 20 minutes into the code.
The first call to the wife was at 1:03 and it started at 12:45.
End of life opportunities. What else? Agreement. Palliative care consult. He did have a pretty significant burden of disease. And Robin mentioned severity of illness not recognized. Dr. Perry, if you wouldn't mind coming off mute, could you speak more to the palliative care consult and what you're thinking in that space?
Yeah, I think this is a gentleman that from the moment he hit the ER door, he was set up for failure. This was something that he had a lot of potential for badness, and a lot of badness happened. It's not recognizing that potential for badness, not just in the current hospitalization, but just overall. I mean, he had, kind of a poor protoplasm. Like he had bad things to start with, not outlining, did he want all of those surgical interventions? Did they understand the ramifications of all of those? The code status, it seems like we set this patient up for failure.
The amount of skin issues, lower extremity skin issues that Dr. Beal presented was pretty overwhelming, indicating nutritional status, overall health, etc. And his burden of infection was significant. In some hospitals, I'm not sure palliative care would have been consulted, but a palliative type driven goals of care conversation definitely would have occurred. I think that I just dropped his name. Our palliative care expert in Wisconsin, Dr. Jasic, would call it primary palliative care. So the intensivist at the bedside could have had a conversation, emergency department as well. Other opportunities for improvement. Robin mentioned severity of illness not recognized. I would absolutely agree with that. And I think that dovetails very nicely with what Dr. Perry was just mentioning. Dr. Beal, did he have underlying pulmonary disease?
No.
But significant vascular disease?
Yes.
Opportunities for improvement.
Hi, everyone. It's Christy. I have a question, Dr. Beal. Did this gentleman have established home care? I mean, VA offers a lot of great programs. We have hospital and home. We have home-based primary care. I'm thinking about things that we could have implemented in his home, too, prior to him getting as sick as he was.
He did initially have some physical therapy that was working with him at home after his surgery in May. And then he also was being seen routinely by wound care, not only for his wound vac and his surgical site, but for those ulcers that he had on both of his legs.
Because I'm
What
just
was
thinking,
the wound vac for? Was that over the surgical site?
I'm sorry?
Was the wound vac over the surgical site?
No, it was his anteriotibial site.
Huh.
And so I'm just thinking again, I mean, when we can get these people into home-based primary care, even hospital and home, I mean, the providers and the nurses go out, there may have been earlier intervention into some of his issues going on if that had been provided for him sooner.
And there may have, I only know the ones that I reviewed while I went through this case. I didn't go through all of his appointments to see if they were happening in home, if they were virtual, or if he was actually coming in.
Other opportunities for improvement. I've been thinking a lot about the concept of the prolonged resuscitation, and I do have to admit that's the longest duration of one where it was a no ROSC established. I've seen resuscitations go on where they code, they come back, they code, they come back, and it's sort of back and forth for a while. But this was significantly prolonged. Was it the same resuscitation team in the ICU that did this whole thing? They must have been exhausted.
So there were quite a few people in this code. It was the ICU team, as well as those codes are called overhead so that we can have responses from other departments. Like pharmacy will send people will come up for the emergency department. The code team from nursing will come up. So we do call these codes overhead. So there is a couple things that I haven't filled you guys in yet that I will, just to see if this stems other conversation. One of the reasons behind this code being so long, not only did the wife request that we exhaust all efforts, but she was right across the street. And so I think that really played into she was just going to get here quick because it literally is right across the street. And I know that being in many codes, if somebody is not calling out the time, you can tend to get lost in how much time has gone by since the start of the codes. And so that was one of the key factors, because we did have some staff in that code who spoke up and said, this has been going on for a while. We've had no return of ROSC or something. I don't know exactly what they said, but something to that effect per the notes. And they had said, maybe we should go ahead and call it. And the code continued on. One of the reasons that was verbalized was because the wife was so close. Working with a lot of family members, there's something about them getting to the hospital where actions are still ongoing with that perception of life. And so when the decision was made to continue on, the first time it initially was because they expected her arrival to be much more quick than it actually happened. If you looked at that code timeline, let me go back. So the code started here at 12:45. We contacted her at 1:03. By the time we contacted her over here at 1:33, we had already exhausted all of our treatment opportunities. Both of those second calls, we had already made it through looking at all of our H's and T's and doing interventions where we needed to. After his spouse did show up, we continued the code for 10 minutes after that.
And she was in the room during that?
Yes.
Melissa mentioned surgical opportunities. Yep, surgical site infection.
And then, so we did culture that wound, and I told you what was growing out of that wound. And this infection was, his surgery was 5/29, and he came into the hospital on 7/18. So clearly poor wound healing was an issue, and his uncontrolled blood sugars didn't help that situation at all, as well as his vascular history.
All right, let's go ahead and please continue as she's presenting what they identified during their committee discussion. If other things occur to you, please type them in the chat.
So these are the opportunities that we identified, as you guys mentioned right off the bat, goals of care conversations. There was a delay in initiating these discussions and engaging in these conversations earlier in the hospitalization versus when patients are actively deteriorating can really help us ensure that the care we're providing is aligning with the patient's values as well as the prognosis and the preferences. As we know in this case, when these discussions are postponed until the patient is actively dying, it really increases that emotional distress, both for the family member and the care team. And it really doesn't help support those informed decisions being made. The second thing we identified was excessive or futile care. And so, as you know, this resuscitation lasted an hour and 24 minutes. We utilized extensive resources, including personnel, equipment, and medications. In this case alone, there were over 18 doses of epinephrine that was administered. Not only did we deplete what was in our crash cart, but we also depleted what was in our Pyxis and had to send staff to the pharmacy to receive more. And so we're lucky enough to have a pharmacist on our multidisciplinary review team. And so she gave us a little bit of insights into the supply that we carry. And she did reiterate that we were by no means in any way to the place where we exhausted our supply. But she also kind of emphasized the importance of using our resources responsibly. And it also brought up questions about continued interventions shifting from being beneficial to being harmful. The third and fourth kind of go together. Well, no, communication opportunities can kind of stand alone. There were missed opportunities for timely and effective communication among the team members, particularly regarding the evolving clinical status and response to the interventions. And then communication with the patient's spouse, while well-intentioned, it presented some challenges in real-time decision making. As I previously talked about, when we contacted her, that second call was at 37 minutes. That third call was at 51 minutes. And by the time she arrived at the hospital, we had been going on for an hour and 10 minutes. It just highlights, that complexity of balancing our clinical judgment with family wishes in high stakes situations and the need for those clear, proactive communication strategies that can both support the patient's loved ones and the care team during these kind of events. And then number 4 and 5 are the ones that go together. That's our severity of illness not being recognized and the deteriorating patient recognition or rescue opportunities. And so just like you guys pointed out, his overall clinical picture, including signs of deterioration, may not have been clearly were not fully appreciated. Of note, the patient did report some abdominal pain the day before his death, and although we did labs and imaging, no significant findings were noted. He also experienced nightly delirium and agitation. On the morning before that code, he had become very difficult to arouse. Could this have been a precursor to the events that happened, a missed opportunity for maybe some early recognition of that clinical decline? And then documentation opportunities. We did have some documentation that was missing, specifically a discharge summary. I picked out the moral and ethical distress because during the resuscitation, I did tell you that the nursing staff had voiced concerns about whether or not we should continue our efforts, particularly after we had identified it and treated all of the reversible causes and had no return of ROSC. And so, there were concerns about the potential for non-beneficial or excessive interventions and questioning whether or not the code aligned with the patient's best interest. And so we really wanted to highlight that when staff speak up and they feel unheard or dismissed, how it can erode the trust of the team and strain those relationships, especially if they believe that something that was potentially beneficial is no longer benefiting the patient. And so some of the lessons we learned.
Communication opportunity for improvement that you mentioned, it was the middle of the night. Was it house staff that were running this, or was there a attending level present?
We had a lot of levels present. We had residents, we had house staff, we had attendings that were present. Now, all of them weren't present the second that this happened, but they were on scene pretty quickly.
Okay. I was just thinking about the moral distress and the nurses and the individuals bringing up what was going on.
Yes, and that was where we really hoped that we would get somebody from, this was early in the morning, so clearly that staff is not usually here in the daytime or during these conversations, because what I heard from them was the term shutdown. And so that led me to questions like, did nobody else back you up? Was it just one nurse that spoke up, or was it a bunch? Did any of the providers in the room that were taking charge of the code, did they hear these comments? Did they, and so there's still information that wasn't there because I didn't have that, some of that key information because I didn't have any of those key individuals to provide additional insights. I did get a lot of information. Our critical care committee also reviewed this case, as did our code review group, and they reviewed this as well. So there's been a lot of really good conversations and things that have come out of this case. And, these are the anomalies. That's why they stand out, but they're the ones that we can learn a lot of things from. Okay, so lessons learned. The team was really good right off the bat with that strong clinical execution of identifying and addressing all the reversible causes and just making sure that all possible interventions were done and not overlooked. I learned something interesting. We used the Lucas device on this patient. Did you guys know that the battery life for the Lucas device is 45 minutes? Because I didn't know that before this case. However, you can replace the battery, and while you're doing that, you can plug it in and it will continue its normal operation. In this case, when the battery depleted, the staff transitioned seamlessly to manual compressions with no interruptions. However, it is worth noting, I was doing a little bit of research, and the reason the Lucas is not designed for prolonged use, its battery life reflects the reality that most resuscitations just don't exceed beyond that time frame. In this case, I told you the situations that kind of led to maybe some of the reasons why this case was prolonged. I thought that was interesting information, and I'm where I worked, we didn't use the Lucas at the bedside. That was more in the field. So I had no idea about the battery life or that it could be plugged in. So I found that interesting. And then resource utilization was another critical area of reflection. And I kind of went into that with our use of medications and personnel. So I won't repeat that. And then, to reinforce that psychological safety and escalation pathways, as well as prioritizing those early goals of care conversations. And so after reviewing this case, I got in touch with our HRO coordinator, and we focused on the importance of staff speaking up and stopping the line when concerns arise. And while they did voice their concerns during this event, the outcome was not what they had hoped for, which showed that we had a gap between speaking up and getting that meaningful action. And so to address this, we brought in the HRO coordinator to our SMR 30 meeting as a guest speaker to acknowledge and commend the staff members who did demonstrate courage by speaking up, but kind of reinforce the importance of fostering that open, respectful communication and discuss how to escalate those concerns further if the response doesn't lead to a resolution. And then we also emphasized the value of leveraging our HRO pillars. Particularly, we were working on the duty to speak up, along with our team training initiatives that strengthen our communication, improve our outcomes. We focused on stopping the line to empower staff to pause those care practices. And then as part of this effort, we also reintroduced the 3Ws framework to guide our communication. And if you are unaware of the 3Ws framework, it is basically 3 statements: what I see, what I'm concerned about, and what I want. And what I see just allows the staff to clearly state their observation. What they're concerned about is clear communication that's succinct. And then what I want is what they're actually looking for, what their desired action or outcome is that they want. And so it's a simple, structured approach that really helps ensure that our concerns are clearly communicated as well as that they're understood. And it supports our culture of safety, team trust, and accountability. And so this is how we leverage those connections within our organization to reinforce those positive actions and behaviors and provide necessary education and support to improve in this area. And so following that internal review, our HRO coordinator then invited me to present this case at the hospital-wide safety committee meeting. And this allowed us to reinforce the importance of communication, the duty to speak up, and the real-world application of our high reliability tools and training. We highlighted the work that's happening at SMR 30 and our structured case review process. And it was just really a valuable opportunity to showcase case-based learning in action and demonstrate how clinical events can drive reflection learning and systems level improvement. It also showed how different areas within our organization intersect and we can collaborate to enhance our care and safety. One key takeaway was the reminder that our most valuable resources, whether people, processes, or insights, they may be found in places that you don't always expect. So if we invest in supporting our employees and educating them and continuing to promote case-based learning, that we can build a more collaborative and hopefully resilient environment that helps us keep improving our care. And so, Dr. Huddleston, I am going to turn this back over to you and let you proceed further if you have any more questions or insights. But I do want to
I would
appreciate.
love to open it up to the floor. I guess it's a relative virtual floor, but open it up to others. Any other comments, things that occurred to you as you listened to this, or any other personal clinical experiences that have paralleled this and lessons learned?
It looks like perhaps education of family members to help them understand what happens during a code. I agree 100%. Did this occur in a training hospital? We are a training hospital. We have providers and clinicians of all levels in various different programs. And this also did happen in July.
My brain, when you said that, dropped immediately into reflection mode, but there have been a number of papers published showing that there is no such thing as a July effect. So I'm not sure that I believe that, but
Well, so I've heard a couple different things, right? So some people will say, oh, it's July, it's the new residents, but those residents aren't by themselves, especially in these situations. And then I've also heard that when you have people that are learning, sometimes these become good cases. And, that's just one of those off the cuff comments that people make, which of course we address that like, yes, we all need to learn, but by no means think of it as practice. People can take those comments in the wrong way.
yes. Heather?
Thinking that with the Lucasen, when a code is happening, you see how everyone gets exhausted while you're doing codes. And usually that's when the doctors and other nurses are looking at each other going, okay, we're going to end up coding one of our coworkers here in a little bit. Do you think it was because of the Lucasen? It just kept going. There was not really any,
Nobody to get petered out. And that's one of the things that helps us lose track of that time. Good point.
I think that is a great point. I had the picture in my head as you were speaking. It's kind of like a metronome in the background in terms of it's a regular cadence, a regular sound. People are not dripping in sweat, which is often what happens with a code that gets very long. Melissa mentioned that she was recently in a code where one participant led into a moment of silence, which I believe opened the floor for healing in a positive environment, to feel safe, to learn and be vulnerable, to learn from our experiences. Wow, what a great moment that an individual stood up and led that amongst peers. All right, I do not have any other thoughts other than this was a phenomenal presentation of a very important and complex scenario, and something that we can all take something away from. And I just find it interesting and not at all surprising that people kept waiting for the wife to show up so they could call it, instead of clinically saying this isn't working. And so that whole family expectations and almost waiting, it felt like almost waiting for permission to stop something that many people in the room must have known was futile. And I think that's all the communication work you did and how you were able to bring things together and have an organizational conversation around a patient's life, the family and the staff, and how it all intersects. It is not simple. It's very complex. And when family is in the mix, it's not only complex, it's complicated. So thank you for bringing this forward. Thank you for sharing the vulnerability of your team and the lessons learned, and for just an awesome opportunity to have a conversation together. And with that, Peace and blessings to everyone. Have a great rest of your week. And thank you immensely for the time that you shared with us today.
Yes,
Dr.
thank
Beal,
you.
thank you.